Fine. Good evening, one and all. This is Priya. I'm from MedWorld Expo, from where this session is happening. This is an unified digital healthcare platform that connects manufacturers, distributors worldwide, while also it brings the hospitals, clinics, laboratories, and healthcare experts like Nikhil sir onto one platform. Today, it's my privilege to introduce our esteemed speaker on the session. When does a brain bleed require surgery? Clinic insights and decision making. Dr. Nikhil Chokam is a highly accomplished neurosurgeon with an impressive academic background of MBBS, MS, and MCH in neurosurgery from Kerala. He currently serves as the consultant neurosurgeon and director at Gautam Neurocare, Kompally, Hyderabad. Beyond his clinical excellence, Dr. Nikhil is also the founder and host of the popular doctors podcast Dopamine with Dr. Nikhil on YouTube, where he shares knowledge and meaningful conversations with healthcare professionals. He is also the co-founder of MedPreneurs and Sarma's Physio and Rehab Center in Kompally, further contributing to the medical and healthcare ecosystem. With his vast expertise and inspiring journey, Dr. Nikhil embodies the perfect blend of medical excellence, innovation, and leadership. We are truly honored to have him with us today to share his insights and his experience. Over to you, Nikhil sir.
Yeah. Thank you for giving this opportunity. Thank you for the MedWorld Expo. Okay. So, should I speak in English or I can use Telugu?
Sir, I think it's better to use English because there are
English.
medical students and people from other states as well.
Yeah,
So
yeah.
we can have a common language as the
Okay.
English.
Yeah, yeah. Yeah, got it. So, I'm Dr. Nikhil, neurosurgeon, so from Hyderabad. So, as the participants were like MBBS students, so let me tell you that how this neurosurgeon, what to do, how to what all to be pursued, what all should be done to do this neurosurgery. So, after MBBS, we have the PG exam. So currently now it is like NEET is there. So in that I did the MS General Surgery, which is of 3 years. So after this MS General Surgery, there will be a super specialty examinations. So in that one super specialty is neurosurgery, like a other urology is there, surgical onco, surgical gastro. Like this neurosurgery is also one of the super specialty there. So as I am interested more in the like brain and spine related things and some emergencies, critical care. So my interest towards this neurosurgery has developed in my MS General Surgery like second year. Okay. So after that, I wrote the MS super specialty examination and I did this MCH neurosurgery from Trivandrum Medical College, Kerala. So it's a 3 years program. So after that, I came back to my Hyderabad, which is my native place. I served 1 year as a consultant in the ESI Hospital, Sanat Nagar. So after that, now I established my own setup, which is a complete neuro center where we deal with all the neurological related and neurosurgery related things. Yeah. So before starting, so anyone can stop, interrupt, and ask me the whatever the basic questions you want, whatever it may be, whether it is the brain, spine, emergency, whatever the basic questions you want to ask, you can ask. I'm happy to give you the answers.
So
Okay.
that's a great
Mm,
intro by you, sir. Actually, for the question and answer, we generally keep after the topic session is explanation is completed by you. They can
okay.
post their questions on the chat box. Once the session is completed, we will be asking that questions one by one so that you
Sure,
can
sure,
take the give the reply, sir.
sure.
Thank
Okay,
you so
so
much.
yeah. So what as a neurosurgeon, what I deal with is like brain. All you know that what is the brain and the spine related, spinal cord, all the nerves related. I deal with. So today the topic is the brain bleed, means the bleeding in the brain. So there will be a lot of questions I see across from the patients, patient relatives. So there will be a bleed. So the bleed in the brain can be a small bleed or there will be large bleed. So So many people at patient attenders used to ask me, sir, whether this bleed in the brain need a surgery or whether not to do any surgery. Like I used to get so many scans from my friends relative. They will send these scans, the bleeding in the brain scan with the CT scan usually, and ask whether these patient need a surgery or not. So that is the technical questions, and where we have to take a decision based on there are so many factors are there. Okay, so coming to the bleed in the brain. So whatever will the bleeding in the brains will be. First, you see like so many accidents we are seeing RTA. So in that there will be a head injuries. So there will be injury to the head. So inside the skull there will be the brain, and there will be a bleeding in the brain. So the one cause is that head injuries due to RTA, that is accidents. Another cause for this bleeding in the brain will be like you have heard about CVS, cerebrovascular attacks, what we call as a paralysis in the common layman term. So in the paralysis also we have the two things like infarct, acute infarct, where the blood supply will be compromised low to the brain. We call it as an infarct. Another thing, there will be a we call as a clot in the brain. So hemorrhagic stroke, where there will be because of the high pressure, high BP, we see there will be bleeding in the brain. That means there will be a rupture of the blood vessels in the brain, and we see a bleeding in the brain. This is one of the cause. And one more cause for this bleed in the brain will be we call as like aneurysms, where there will be aneurysm. What is this aneurysm? Is there will the blood vessel will get dilated. There will be outpoaching, like balloon-like thing will come. So that balloon will be get balloon-like thing will be get ruptured, and there will be bleeding in the brain, which is also an aneurysm rupture. There is bleeding, and there will be some other causes also because of the, some brain tumors also that may get bleeds in that. So the most common as a neurosurgeon, uh, as an emergency things we see because of the head injuries or hemorrhagic strokes, that is CVS, and this and the third thing is because of the aneurysm bleeds. Okay, so first the head injuries we take on the head injuries. So there will be a head injuries we call the EDH, extradural hematoma, EDH, or EDH. There can be subdural hematoma, just another cause of the hematoma, SDH like this. So there will be there. And when to do this surgery? See, any patient we are operating in the neurosurgery on the brain in an emergency, we assess one score. Glasgow Coma Scale will be there, GCS. Okay, based on the score, like usually the score will be a 15. Like in the what is this GCS means? Like three three things will be there. Like IEVM, eye opening. EV is verbal, M is the motor. So based on this eye eye-opening verbal things and the motors for whether he's obeying our commands or just his limbs, upper limbs and lower limbs are moving because of just pain. Based on this, we'll assess one score. So usually normal score is like 15. If the GCS that 15 is score is less than 15, like 14 score is also okay, but when it comes to like 10, 11, 12, 13. So there will be decrease in this GCS, Glasgow Coma Score, which is a useful score for any neurosurgeon to take a decision whether we should operate the person or not. That is the thing. So if there is a bleeding is big bleeding is there, and based on that will be the volume will calculate. Bleeding is big, as I know, sir, the patient score, that is Glasgow Coma Scale, is low, means less than 14. So it can be 13, 12, 10, 11, 9, 8, whatever it may be. Big bleed, score is low. Okay, we'll take a decision of operating the patient. Okay, so bleed, usually the size of the bleed and the GCS, Glasgow Coma Scale score. And one more thing, inside the brain, there is a term like we see usually in the reporting of the CT scan. Midline shift we call it as like MLS. Midline shift means the see in the brain we have the right side and left side. If there is an injury on the right side, imagine the right side clot is there. The clot will compress the brain from the right side. So when the clot is compressing from the right side, obviously it get pushed to the left. So that is the midline shift. From right, the brain is pushed to the left. So we call it as a midline shift, MLS. So my MLS will be like 1 mm, 2 mm, 3 mm. Like if the midline shift is more than 5 mm, means more than 5 mm, like 6, 7, 8, 9, 10, like that, whatever. This is also one of the important criteria to operate. So based on the size of the bleed, patient score, that GCS, which is will be low, less than 14, like this, 13 or below 13. And the another thing is midline shift, MLS. So based on this three and some other parameters also there, mainly we take criteria to operate or not based on these three things. Okay, then we'll take a decision to operate. So if whatever it may be, the counterpart to this, that means bleeding is small bleed, GCS is good like 14 or 15, and the midline shift is less than 5 or less than 5 mm. We don't take an decision to operate. So we take the patient for admission. We'll observe for 3 to 5 days. We'll use the medications like anti-epileptics, like seizures. Usually, this bleeding patients has the potential to get a seizures. We call as convulsions or fits. So the treatment of seizures we'll give, and the bleeding in the brain that cause some edema surrounding that bleed. So we give the medication. Usually we give the mannitol, as you have heard, I think in pharmacology, mannitol, or we'll give or 3% NaCl. These two things we based on some indications and contraindication. We these two things, mannitol and 3% NaCl, we use this as the anti-edema. Okay. So these are the some of the medications we use for the conservative treatment for the head injury patients, like bleeding in the brain patients. We'll observe for 3 to 5 days, and daily we'll assess the GCS score. And after 24 hours, we'll take a repeat CT scan and compare with previous CT scan whether the bleeding is increasing or not. Like that, we take alternate day scans also. Taking alternate day scans, assessing whether the bleeding from previous scan is increased or not. An important thing, assessing the patient Glasgow Coma scale. And there can be a scenario also. At this current moment, the patient, the bleeding can be a small. The patient GCS, Glasgow Coma scales, the score will be also normal. But sometimes there will be a sudden increase in the blood. Internal hemorrhage, the blood vessels started bleeding inside. The patient's score, the GCS may get decreased. Immediately we take a CT scan at that time and we'll assess the size of the bleed. If the bleeding is increasing, immediately we take the emergency surgery, whatever it may be. Like as you know, that neurosurgery is emergency. There is no elective thing in a head injury with low GCS pressure. Whatever in the night, 12, 1, midnight, early morning, whatever the time, we take the patient for surgery if there is a fall in the GCS or increase in the bleed. So these are some of the things related to head injury. So head injury, extradural hematoma, EDH will be there, HDS, subdural hematoma will be there, or many times there will be a direct injury to the skull bone. The skull bone may get depressed, go and prick the brain. So depressed fracture, we call it the depressed fracture. So these are the some of the things in the head injury. I'll tell you about what type of surgery we will do, what is the procedure also. I will explain you briefly. So this is one of the things, head injury. Yeah. So this is regarding the head injury. Anyone want to ask question, or shall I continue the next cause for the bleed in the brain?
We can have questions at the last, sir.
Okay, okay, sure, sure.
Okay,
Okay.
after the session is
So,
complete.
I mean, anything? Should I make slow? Am I audible?
No, is
Any
it that's
voice
good to
clear?
go, sir. It's good to go. No
Yeah,
problem.
yeah. Anyone can comment in chat also. Please post your question. Okay, what are the yeah, yeah, fine. I'm getting the questions. Yeah, good questions I'm getting. You can message me also, like if my voice is not clear or should I make it slow. Also, feel free to message me. So second thing is we call it like the cause for one of the cause for bleeding in the brain is that we call as hemorrhagic stroke, CVA, cerebral vascular attack. As I said, this is a common layman terms, common paralysis, hemiplegia. There will be a weakness of the one side. So as you know, no, like, I think you have heard that whatever the things happen in the brain, the clinical presentation on the body will be opposite. So like that, if the stroke, paralysis, bleeding, or infarct will come in the right side, the patient will get the weakness on the left side of the hand and left leg, left lower limb. Opposite will be there. Similarly, if there is a stroke, what you call like infarct or hemorrhage on the left side, the patient will get the opposite side, right side. There will be some like physiology thing, but anatomy thing like corticospinal tracts, corticospinal tracts will come crisscross in the brainstem related. That all this is all the anatomy. That's why we get that opposite thing. Remember this. It's very see neurology or neurosurgery assessment of the patient is just like a mathematics. If you have the clear concept in it, you can diagnose the patient very clear. But in the same way, if you don't put the brain that is where the neurology or neurosurgery, your total diagnosis will be wrong. So obviously the treatment will be wrong. So that is it. So yeah, coming to the hemorrhagic stroke, we talked about now hemorrhagic stroke only. So in that, in this hemorrhagic stroke, so I'll show you the brain small model also. Everyone can see this. Can you see no brain? Yeah. So as so this is the brain. Okay. This is the left side of the brain. This is the right side. In between there will be the marker. We call it the hemispheres, two hemispheres. And all you know the brain and then there will be a lobes, frontal lobe, parietal lobe. The side part will be the temporal lobes. This is posterior will be the occipital lobe, and this is the cerebellum. I think this is all the anatomy. Okay, so this is the brain now. So yeah, coming to this hemorrhagic hematoma we call intracerebral. I see bleed we call intracerebral hematoma. So this is the brain. No, the bleeding will be inside the brain, inside the brain camera, brain parenchyma, means inside the substance of the brain, there will be the bleed. Okay. So obviously, the bleed based on the size of the bleed, volume of the bleed. Usually, uh, 40 or 50 ml of the bleed inside the brain is very critical. Okay. 40 or 50 ml. How this 40 or 50 ml is calculated means that will be based on seeing on the CT scan. We will calculate that volume. Volume, you know, no? Based on the CT scans, our radiologist also will use on the volume. Okay. So volume around 40 to 50 ml of the volume. Will if you 40 or 50 ml of the volume, that is the one criteria. And obviously same. Anywhere in the brain hemorrhage surgeries, the concept is when first see the patient GCS, that is Glasgow Coma Scale, okay, size of the bleed, okay, and as I said, no midline shift MLS. 5 mm above, that is 6, 7, 8, 9, 10, 11, whatever it means. The midline shift can be up to 15 mm also. Okay. These three are the main criteria. Okay. So in that case also, we operate the patient. And there can be small hemorrhages. Small hemorrhages are small hemorrhages. The volume or about 10, 15 ml, 20 ml. Small, that means 30 or less than 30 ml of the volume of bleed. Again, same patient GCS, again 14 or 15. And midline shift is again 5 mm or less than 5 mm. Same, we try to manage conservative. So you know, no, conservative management and surgical management. Conservative management means with medications, we'll try to like cure the patient. Same anti-epileptics, we'll give, observe the patient, take repeat scans. Okay, based on that, we'll treat the patient. Same if the patient GC is getting decreased. Today morning, the patient got admitted. Evening around 6 or 7 o'clock, we see the patient. We assess that his GCS has fallen. Immediately, we take a CT, compare the CT from previous, whether the bleed has increased, midline shift has increased. So these all already immediately take this for emergency surgery. Okay. So this is one of the cause for the internal bleeding in the brain that we call as IC bleed. Okay. So coming to the next cause of this bleed is one of this aneurysm. Okay, aneurysm rupture we call it. There can be if there is like what is it, the blood vessel we have that outpouching. Okay, and the outpouching will get burst, and there will be a bleeding inside the bone. Aneurysm bleed. In that we have the subarachnoid hemorrhage stage. Okay. So see, based on the history wise, we can say that that bleeding is caused by RTH. If there is road accident, if there is EDH and SDH, obviously it's caused by due to RTA. There is that. If the patient is having high BP and pattern of the bleed is inside the brain, inside the parenchyma of the brain. Okay, so we think it as like hypertensive bleed. And this aneurysm bleed, the hemorrhage won't be like a EDH hematoma or SDH. Mostly it won't be like that or inside the brain. Mostly the pattern of bleed will be SH, subarachnoid hemorrhage. So based on the CT scan, we can guess like it is whether it is caused by any RTA, hemorrhage due to aneurysm. So knowing the pattern of the bleed we are suspecting on the CT is the aneurysm bleed, immediately we advise one CT angiogram of the brain, CT angio of the brain. In that, what we get to know is we'll know whether it is caused that SH, the bleed is caused by aneurysm or not. Okay. So based on this aneurysm, when we have like anterior cerebral artery, medial cerebral artery, PCA, posterior cerebral artery, PCOM artery, circle of Willis. I think you have heard of the circle of Willis. So this aneurysm bleed from which this aneurysm will get to in CT and whether it is from the anterior cerebral artery or MCA or PCA or PCOM or whatever it may be. Get a diagnosis also the aneurysm rupture is from middle cerebral artery. So based on that, after that, we'll take a decision. Mostly aneurysm bleed, we'll do a surgery. I will tell you what surgery will be done. Major causes for the bleed in the brain, RTA, hemorrhage, that is hypertensive bleed, CVA, we call one of the type of CVA, and aneurysm bleed. And some other causes like CSVT, cerebral sinus venous thrombosis, also that can cause hemorrhage. And this brain tumors, you hear the brain tumor, no? Sometimes the brain tumors also may turn into hemorrhage. That also can cause bleed. Okay. So these are some of the things. Now getting one of the interesting topic is what surgery we will do. Okay. So as you know that like brain surgeries are very critical. The outcome patients, the morbidity, the patient's prolonged ICU stay. Patient will be prolonged on the ventilator. There will be like patient like 2 to 3 months on the ventilator. As you know, the layman terms called as a coma. Okay. Um, so the important you see in neurosurgery, especially the brain. Oh, hear me now?
Yes, so we can hear you. We okay. No, sir. Still, the network is little bit less from your end. Can you please change your Wi-Fi network, sir?
Yeah, one minute. Yeah. Is it okay? Hello?
Yes, sir. Now the voice is clear, but video is not that clear. But it's okay, sir. You can continue. Still, it is little bit
Video,
less.
video is fine for me. Okay, okay. So coming what I said, everything is one third. What is
Still, your voice is getting glitch, sir.
pre-operative?
Still, your voice is getting glitch, sir.
Yeah.
I think you can try some other network, sir, because it is not
Hmm.
working, I guess. Hello, sir. Are you there?
Hello? Yeah, now?
Yes, sir. It is
I'm
completely clear
audible?
now. Yeah, it is clear, sir.
Yeah,
It
yeah.
is way more better than that.
Okay, okay.
Yeah, I think we can
Okay, okay,
continue.
fine. Yeah, yeah, yeah.
Thank you, sir.
So yeah, yeah. What is this one third? One third is like pre-operative assessment. So before taking any patient for the surgery for the brain, the critical organ, you should assess the patient blood parameters, okay, his conditions, read the scans correctly, and make a decision to operate. See, if you take any orthopedics like bone surgery or bowel surgery, that is all the elective things, and bowel surgery also all the bowels, abdomen, you can whatever the areas you can do, you can go and search in the abdomen. Like it is, there will be free movement of hands in the abdomen as it's a very big space. Like that in the brain, you can't do in the wrong place or some other because all you know that there will be so many of neurons. If any one wrong small of wrong step, the patient may get a complication of the deficits, that is weakness, paralysis. It will get. For that only, before taking any patient for surgery, we should see the scan, assess, position the patient, decide the treatment plan, everything. So this is the one third. One third is the good operative thing. That is the one part. And remaining one third is the post-operative care. In the neurosurgery, especially the emergency patients where they will be staying in the ICU for a long time, the post-operative care is very important. Important. What is this post-operative care means? Proper ventilator settings, daily seeing the patients, daily assessing the blood test, how they are, any abnormal is there. And because of this prolonged ICU stay, patient may get infections, nosocomial infection we call it, or ventilator associated infection, ventilator associated pneumonias, urinary infection, urinary tract infection. These all things will be there. So that is why you have to give the proper post-operative care. It is not like that doing the surgery and leaving the patients. No, no, it's completely different thing in the brain surgeries. Okay. So coming to this, what surgeries we will do in the brain in an emergency? So usually, see, the main concept in the brain surgery in the emergency is we know we have here there will be a hypothesis like Monroe Kelly doctrine hypothesis. So what is this mean? See, our skull inside the brain is a closed cavity. So it is also the skull. Nothing is the bone. Inside the skull there is a brain. Okay. So usually in brain, this all there will be like this brain parenchyma. The soft thing is the brain parenchyma will be there, and covering this brain you have here I think like CSF, cerebrospinal fluid will be there, CSF, and this all no, obviously the blood will be there. These three will be there like brain parenchyma, blood vessels that is blood, and cerebrospinal fluid. So these three will be accommodated. Like sometimes the three will be accommodated. So if one minute. These three will be get accommodated. So what happened, after in this brain hemorrhages or bleeding in the brain, till certain time, certain part of volume, it can accommodate. It means if there is a bleeding in the brain, there will be sometime decrease in the brain camera. Means brain camera it will get shrink, or CSF will be decreased, or blood volume will be decreased. So there will be sometime space. It can give space to that fourth factor. The three factors. What are the three factors? Is that brain parenchyma, cerebrospinal fluid, and blood. The three will be adjusted. If something is getting lowered, another will get adjusted to maintain this brain contention. If there is a fourth factor, like fourth person, like this bleeding or any brain tumors is there, suppose there is a bleeding of 30 or 40 ml of the volume of the bleed. So this CSF, this blood or brain damage get decreased to get accommodate further up to certain time. When these three parameters cannot accommodate, it will go beyond their limits. Then the pressure symptoms in the brain starts. That's why because of these pressure symptoms only, the patient GCS, that consciousness level will decrease. That is the main concept. So what we'll do is see the fourth factor, the fourth person is entering. Okay, the three persons will be adjusted up to certain limit. Up to certain limit. If that fourth person is causing some like what to say, some issues, these three persons should decide what to do now. In the same way, this bleeding up to certain volume is enough. If the bleeding is getting increased, we have to accommodate some more space. The some more space. Can you hear me?
Yes, sir, we can hear you.
Yeah. Okay.
I
Okay.
think you can see the chat box also. We already have few questions in the chat box, sir. You want me to read it out for you, sir?
Chat box.
Yes.
Main chat. No, I see now, but now I can't see any questions.
Since you have rejoined after there was a network issue, right? I'll read it out for you, sir.
Okay, right, yeah. So, yeah. So, what I'm saying, yeah. So, we should provide some space to that fourth person. So, that is what the surgery in the brain we call this craniotomy or decompressive craniectomy. Craniotomy and craniectomy. What is this surgery? We'll post for surgery and we'll remove the bone part, half of the right side, whether we are operating on the right side or left side. Some
So,
part of the bone we'll remove. Hello?
sorry to interrupt, sir. We can't see you actually.
Mm, now? Yeah.
Now it is better, sir. Yeah.
Yeah. Hmm. So whether it is on the right side or left side, we are going to operate the patient. See, in this main concept is we'll remove some part of the bone. Okay, that is called craniectomy or craniotomy. One part of the bone will remove, and after removing the bone, there will be the many meninges, that is dura mater, arachnoid pia mater. Main thing is dura. We'll open the dura and we'll remove that clot also will remove whatever we will removing means we'll take a suction cannula and suck the bleed. Clot will suck, and after sucking the blood, the compression, the pressure will be decreased, and this bone thing. Two things here: craniotomy and craniectomy. I said no. See, after removing the brain, after removing after removing the brain, after removing the brain, not after removing the skull, after removing the bleed, we'll see the brain condition, parenchyma condition. If still it shows some pressure, bulging, we'll remove that skull and keep in the abdomen. Abdomen, it means abdomen is not inside the intra abdomen, just in the, what you say, like subcutaneous layer of the abdomen will keep that bone, and for 3 to 6 months we'll allow the brain to go adjustments, expand in the skull, and after 3 to 6 months of the patient recovers and come back, we'll replace that bone which is kept in the abdomen back to the skull, that is called as cranioplasty. Okay, so that is the craniectomy. Ectomy means removing. What is this craniotomy? Otomy means after removing the skull bone, after removing the blood clot, if we see that brain is not bulging, it is soft only, there is no bulging, we'll keep back the skull bone there only. We'll fix with some plates and screws, we'll fix it. So there is a craniotomy. So this is the main concept, that is removing the skull bone, providing the brain to get expand, accommodate, go whatever the changes it go. Till that time we'll remove that bone. I think you have seen some images in videos also. What you say, you see the patient's skull is sunken here, the brain is sunken, some videos, photos here. So that is only the surgery what is done. So in the same way for this head injuries and for hemorrhage also, we'll remove the blood clot. Removing blood clot is nothing but sucking. We'll suck that blood, remove it, take off the bone, keep in the abdomen, or after the patient recovers after 3 to 6 months, we'll call the patient, replace the bone back on the head. It is called cranioplasty. So these are the two things of the surgery things, and we have spoken about the aneurysm also. Aneurysm surgery. That aneurysm, simple. That is nothing but there is it's a high complex surgery. That aneurysm balloon bulging will be there now, bulging the neck part. We'll do a clipping of the aneurysm, we'll call. It means that we clip the neck part of the balloon. You imagine the balloon, we'll tie a thread there. In the same way, we'll apply a clip there so that further bleeding will be stopped. And now, because recent advances, there is the intervention, like how you do stents for the heart, cardiac stenting. The same way, for the vessels in the brain, there is a intervention procedure. Like we send a catheter, uh, do a coiling in the aneurysm, that bulging part, or stenting, whatever it may be. So main thing in aneurysm, we'll do a clipping or coiling. And for the emergency, other hemorrhage, hematoma, or head injury, we do a decompressive craniectomy, that removing the skull bone and everything. In the same way, after this surgery, we'll shift the patient to the ICU, connect to the ventilator, assess the patient GCS, Glasgow Coma Scale. If the GC is getting improved, patient is obeying, slowly we'll disconnect the wean off, disconnect the ventilator. The patient is improved, keep some days in the ICU, shift to the ward, and we'll discharge. The patient GCS is not improving and the patient needs a prolonged ICU stay. Until the patient takes spontaneously voluntary breathing or the patient GCS won't improve, till that time we'll connect the patient to ventilator on. So that's why I said in the earlier, prolonged ICU stay is expected in the emergency neurosurgery patients. Okay. So these are the things, three things, the causes of the brain bleed and what surgeries we'll do, when conservative will be managed, and when surgical management is done. So these are the three causes, main causes. That is what I explained now. Yeah.
Okay, sir. So
Yeah, yeah,
should we go?
yeah, you can.
Okay, sir. We have a question from Akash. What are the most
Yeah.
common causes of brain bleeds that may require surgical intervention?
As I said, no, that is, three main things: head injuries, extradural hematoma, subdural hematoma. Second cause with hemorrhage because of the hypertensive bleed. Third is the aneurysm. These are the most commonly we see. Three, and fourth cause the brain tumors bleed also, or any CSVT bleed. So main three things is because of RTA, hemorrhagic stroke, aneurysm bleeds.
Okay, sir. And we have a question from Amit. Are there specific symptoms that indicates an urgent need for surgery?
Yeah, I said, three parameters: GCS, Glasgow Coma Scale. Okay, so you are asking about clinical. Yeah, see how I am speaking, you are speaking. This all the full. We are the full GCS patient, 15 patients. Imagine we are. Imagine I'm not opening my. I means the patient is not opening the eye. If you ask his name, he's not verbalizing or not verbalizing, not confused. Only sounds he's making. Okay, M is the motor. Is for is if we see in motor, we'll ask the patient obeying. We see whether the patient is obeying or not. We ask the patient tell your name. If he's not saying his name, or we'll ask the patient to lift his hand. If he's not obeying, means the G says is low. So these are the some of the parameter clinical. Mostly by seeing the patient, you will get to know whether the patient is what you say serious condition or not. In that way,
Okay, sir.
we'll assess when we get after. 1 minute. Listen, in meeting lo unna tarvata. Yeah, tell me.
We have another question, sir. Like, what are the latest surgical techniques used to manage brain bleeds?
Yeah. Latest surgery techniques means, see, for emergency, this decompressive craniectomy. Skull bone removal is the standard from what you say, falling since so many years. Coming to the hemorrhage, I said no, second cause that hypertensive bleed. Okay, continue.
Yes.
Can I
Yes.
continue? Yeah. For this hypertensive bleeds, instead of removing big skull bone, there is some endoscopic. Endoscopy. You hear no endoscopic.
Yes.
How in general surgery laparoscopy. In the same way, endoscopy procedures can means no need to open all the skull. Just open small hole, pass the endoscopic camera, see where is the blood clot, suck it. So these are the some of the latest technology we can see.
Okay, sir. We have this last question from Danish. Hello, hi, sir. Good evening. How do you balance the risk of surgery versus the risk of leaving the bleed untreated?
Yeah. So good question. So see, if the patient is very young, 20 years, 30 years, 40 years, up to 50 years also, we'll explain the patient attendance. So that is what I said. No, I get a lot of questions. How much percentage guarantee you will give? 100% success rate. And even the patients will ask, what is your track record success rate? So in medical, there is nothing 100% guarantee. If anyone is saying I will give 100% assurance, also don't believe it. So nothing is 100%. We usually take the terms like major, there is 70%, 80% guarantee, 90% like the guarantee. So this only, if young patients will, if there is a 1% chance of survival, also we'll advise them to go for surgery.
Okay, sir.
So imagine a 70 years old, 80 years with a big bleed, GCS score. Naturally, like of say this 70, 80 years also. If you operate also, at the same time, uh, cooperation from the bodies, his immunity is also very important. Operating on a 70, 80 years old age man and operating on 20, 30 years, 40 years, there will be variation in the body response. So in that way, we'll advise some patients, if there is 1% chance, go ahead for surgery. This old man, nothing to do. We'll ask them to just wait and watch. If he improves, it's okay. Or if you don't improve, anything happens, you just prepare for it.
Okay, sir.
One more question is there. How does the location of the bleed influence the surgical decisions? Sir? Yes, yes. Location of the in the brain, there are the important critical structures areas. You can see no this.
Yes.
Yeah, you can see now.
Yeah, we
This
can see
brain,
it.
brain parenchyma bleed. There is also okay. We can remove posteriorly. This is the cerebellum, this brown color thing. In this also bleeding is there inside the cerebellum. Also there will be a bleeding. How the bleeding in the parenchyma of the frontal lobe, parietal, temporal. In the same way, bleeding can be in the cerebellum also. We will operate. There is another structure in the brain called, this is white color, brain stem, where there is brain stem is nothing but is made up of midbrain, pons medulla.
Okay.
That is some of the critical area, that brain stem, no, where we have the respiratory center, cardiac center. Usually, the bleeding in that brain stem, 99% there will be mortality. So we prefer not to operate, touch that patient. We'll just connect to the ventilator. We'll see. Other parts of the brain, mostly we will operate. Not issue.
Okay, sir. That's all in the questions. With that, we have questions in chat box. So before I wind up the session, I just wanted to share my screen and talk about MedWorld Expo, and then we can wrap the session, sir. Is that okay?
Yeah. Before that, just
Thank you
I
so much.
want viewers to all the doctors subscribe my YouTube channel. There is a channel. Just go and search dopamine with Dr. Nikhil. See dopamine. You know, no dopamine with Dr. Nikhil. Go and search in that and just subscribe. So I do podcasts with all the specialty doctors like orthopedics doctors, skin doctors, cardiologist doctors, all the you have the good reliable information, because as I'm a post doctor, I'm going to ask the questions which are very useful for the common people, and all the information will be reliable. So please subscribe Dopamine with Dr. Nikhil channel. Yeah. Yeah, tell me.
Okay, sir. I'll share the video link in the chat box also. Maybe click on the chat box. I just wanted to share my screen and talk about MedWorld Expo for just a minute, 2 minutes. So thank you all for joining the wonderful session. Before I wind up the session, I just wanted to talk about MedWorld Expo. Since we have a prestigious speaker today, Dr. Nikhil sir, and we have a lot of medical students and few practicing doctors in our session, I just wanted to tell how MedWorld Expo is beneficial for them. So MedWorld Expo is a unified healthcare digital platform where we will help you to network with manufacturers, distributors, and healthcare service providers, which means doctors, healthcare professionals, any hospitals, all kind of healthcare or related people into the platform. So what would be the major benefit as a doctor or a medical student in our platform? As you can see, we have a separate option for medical service providers where you will be able to find doctors, hospitals, laboratories, and other healthcare service providers. So this is one thing, and even you can attend a free webinars in our platform. Even you can attend CME programs, and we have latest news and insights page where you can find all the latest healthcare and medical updates in our platform, where we have MedWorld blogs as many of the students who are interested to write blogs about any kind of small topics, they can directly come to MedWorld blogs and they can write blogs like this. So if you can see, we have few blogs written by medical students and few doctors also. Even you can also create an account and you can directly write medical blogs in our platform. And we have medical communities. If you are into any particular specialty and if you would like to join any kind of medical community with other doctors and connect with them and make your network, so MedWorld is the right choice for you to connect and find out the right doctors to you, doctors with them, or medical students also. So you can join MedWorld Expo and you can join medical communities in our platform. We have healthcare journals also in our platform, and we have global med magazines also. So we have career advancement option also, where we will be helping out to you. If you wanted to study abroad, we will be helping out for you to find the right place where you can go and how do you need to apply. All the process will be explained clearly in our platform. And we have a job platform option where you can browse all the latest jobs outside the like within the healthcare network. So that would be wonderful opportunity for you to find a right job for you. So this is all about MedWorld Expo. So thank you so much, sir, for giving us this opportunity, like for hosting you. Thank you so much. Hoping for much more sessions with you. Thank you so much for your day. Have a good day, everyone. Would you like to say some closing notes, sir?
Yeah, that's okay. Thank you. Thank you. Uh, Reach me for any suggestions in your career, which branch you want to take, how this branch, whatever it may be, you can reach me. So I am available in my neuro center, Gautam Neurocare, Kompalli, and anyone from Hyderabad, Telangana, doctors. We have forming a community of the medpreneurs. So what is medpreneur means? All the doctors, MBBS and allopathy doctors with entrepreneur mindset, who want to know about the finance, who want to establish the hospitals. They can join in our community. That is medpreneurs. So you can take my number from the organizers. Feel free to WhatsApp me. I'll reply you whatever you need.
Thank you, sir.
Yes.
Thank you so
Thank
much.
you. Thank
Have
you
a
for
good
the
day.
opportunity. Yeah.
Thank you, sir. Have a good day, sir.
Okay. Yeah.